Hi everyone. In the today's section, we see about some basic medical terminologies we come across in our profession, that is dyspnea, cough, and respiratory obstruction. First of all, we see about what is dyspnea, and in this section, we learn about what are the etiological factors or the causes of dyspnea, what are the features of dyspnea, and what are the management we supposed to adopt in case of dyspnea. So firstly, what is dyspnea? Dyspnea in the sense that is a shortness of breath and difficulty breathing are collectively called dyspnea. It's a quite common medical terminology we come across with each and every patient we take care of. So we supposed to know what is dyspnea. Every day of our clinical experience we hear about this condition or patients come across with the dyspnea. So we definitely know about what is dyspnea. So dyspnea is a shortness of breath and otherwise it is termed as difficulty of breathing, which is known as dyspnea. Then the respiratory rate may be increased or decreased, though the respiratory effort is usually increased with the use of accessory muscles. Hope you all know about the accessory muscles. That is, when patients develop dyspnea or shortness of breath, they feel this air hunger or they come up with the labored breathing. So definitely they use accessory muscles. That is one of the feature we can identify. The patient may show signs of progressive fatigue and impaired gas exchange. Impaired gas exchange, that is also one of the important process. That is a gas exchange, the normal inspiration expression mechanism. So when there is a dyspnea or there is a shortness of breath, patients have a develop with the impaired gas exchange. That is, there is a difficulty with the oxygen intake and as well as the expression of carbon dioxide. Here we see the etiologies for dyspnea. So etiological factors are categorized into three categories: cardiac causes, pulmonology causes, and cardiac and pulmonary causes. So the cardiac causes are congestive heart failure, coronary heart disease, cardiac arrhythmias, valvular heart disease, cardiomyopathy, left ventricular hypertrophy, and pericarditis. In all these conditions, there is a increasing fluid volume in the heart as well as a congestion in the respiratory tract. There is a pulmonary congestion will be there. So that leads to impaired gas exchange as well as the patient develop with the dyspnea. Next is the pulmonary causes. The pulmonary causes are COPD, asthma, interstitial lung disease, pleural effusion, malignancy, bronchiectasis, hereditary lung disorders, and pneumothorax. These situations also, for example, COPD. COPD is a chronic obstructive pulmonary disease, whereas the asthma is a obstructive pulmonary disease. Similarly, interstitial lung disease, pleural effusion, malignancy, in all these situations, there is a pulmonary congestion. When there is a pulmonary congestion, there is a air trapping, otherwise decreased air entry and otherwise decreased gas exchange in the pulmonary system. So ultimately that end up with the dyspnea. Then non-cardiac and non-pulmonary causes are thromboembolic disease, psychogenic causes, pulmonary hypertension, obesity, severe anemia, gastroesophageal reflux disease, metabolic conditions like acidosis or uremia, liver cirrhosis, neuromuscular disorders, especially myasthenia gravis, chest wall deformities, and upper airway obstructions. Here also, especially there is a thromboembolic disease in the sense there is a emboli from any part of the body that will move and that may enter in the pulmonary capillaries. So pulmonary capillary blockade as well as the congestion develops. Then psychogenic causes, that is because of psychogenic factors there is a hyperventilatory stage. So the patient feel dyspnea. Similarly, obesity, anemia, GERD, all these situations there is a over demand of oxygen in the body. So body do not meet adequate oxygen, so it demand more oxygen. As a compensatory mechanism, lungs supposed to work more. So patients develop with the dyspnea. Then the grades of dyspnea. Here we see the classification. Grade 1, that is a minimal dyspnea. So in minimal dyspnea, the feature is not troubled by breathlessness except with strenuous exercise. So usually they don't have dyspnea or they don't have shortness of breath, but when they perform certain aggressive work or strenuous activities, they come up with the minimal kind of dyspnea. Then grade 2 is a mild dyspnea. Here the troubled with by shortness of breath when hurrying on the level or walking up a slight hill. In the sense, as a normal activity, they may not feel dyspnea, but when they perform something fast kind of activities or they climb the hill in the sense climb so fast, such situations they feel shortness of breath. Then Grade 3, there is a moderate dyspnea. Here, the breathlessness when walking at own pace on the level. In the sense, according to the age group, they have some kind of speed or pace in their walking activities. So, in such situation also, in their own pace of walking activity, they develop breathlessness when they walk a while. That is what the moderate dyspnea. Next, the grade 4, there is a significant dyspnea. If that is the feature we see, they stop for breath after walking a few minutes on the level. As it is said earlier, then according to their age group, according to their level of activity, when they walk for a distance, they are supposed to stop. In the situation, they stop to take breath. That is what the significant kind of dyspnea. And grade 5 is incapacitating. In the sense, that is the severe stage of dyspnea, that is breathlessness while doing mild activities. In the sense, mild activities like their self-care activities like feeding, dressing, undressing, or their combing, taking bath. So when they're performing even their self-care activities also, they develop breathlessness. That is a situation of severe dyspnea, that is incapacitating, or the grade 5 dyspnea. Then see what are the clinical manifestations of dyspnea. First one is clearly audible labored breathing, anxious, distressed facial expression, flared nostrils, protrusion of the abdomen or chest, changes in movements of the chest, ribs and abdomen, and cyanotic features, that is bluish discoloration in the peripheral areas or the peripheral body areas. Changes in heart rate. When there is a dyspnea, ultimately there is a change in heart rates, most often increased heart rate, and changes in respiratory rate. There is a tachypnea or increased respiratory rate. These are the clinical features. When they have a dyspnea, definitely we can hear the breath, sound of breath. That is what it is says, clearly audible and labored breathing. Then what are the diagnostic measures? First and foremost is history and physical examination, complete blood count. In complete blood count, we could identify if the patient is anemic or not. Similarly, whether the patient's hemoglobin level. Then when hemoglobin level decreases, there is a decreased oxygen carrying or decreased level of oxygen is getting to the peripheral body area. So through the complete blood count, we can identify that. Similarly, where there is an impaired gas exchange, in the ABG analysis, we can recognize that. Yeah, there is ABG analysis, there is arterial blood gas analysis. In this, we can identify the blood pH level, partial oxygen concentration, partial carbon dioxide level, and bicarbonate level. When comes to the ABG analysis, the normal pH is 7.35 to 7.45, and partial oxygen level is 80 to 100 percentage, and partial carbon dioxide level supposed to be 35 to 45, and bicarbonate, that's CO3, that is 22 to 26. This is a normal parameters. When there is a variation in this, that is represented by acidosis or alkalosis features. Then chest X-ray. In the chest X-ray, we can recognize what is the exact underlying reason for the dyspnea. ECG and echo. There is a ECG in the sense electrocardiograph as well as echocardiogram. So in these things we can identify cardio related conditions, any abnormality is there or not. CT scan, we can clearly picturize the thoracic conditions. And PFT, that is pulmonary function test. In pulmonary function test, we recognize the lung capacity and all. Lung capacity, that is tidal volume, expiratory volume, and inspiratory volume. So and all we can recognize, identify in the pulmonary function test. And bronchoscopy. Bronchoscopy in the sense there is a visualization of bronchi. Bronchoscopy, there is a diagnostic procedures as well as it is a therapeutic procedure. So as a diagnostic procedure, we use a fiber optic tube which is inserted and visualize the bronchi. Recognize the quantity of secretions, and we identify what is the reason for the dyspnea and all. And treadmill test to check the treadmill test, otherwise we say it is a stress test to identify the capability of the heart to meet the metabolic demand of the body. Next is management for dyspnea. That is, management is based on the condition. So first and foremost, when the patient has dyspnea means start with the oxygen therapy to maintain the saturation. So ideal saturation supposed to be more than 90 or more than 95 percentage. Usually 100 percentage we can achieve. So we check by the spirometer. So saturation level supposed to be more than 90 to 95 percentage is the ideal. Then correct abnormality where possible. Correct abnormality in the sense, already we said certain causes for the dyspnea. So identify the exact cause for that, then treat the cause. Then patient will be relieved from dyspnea. Then support therapy until recovery. Supportive therapies are mainly two. That is mechanical therapy, that is positive pressure ventilation or continuous positive airway pressure. And next is the pharmacological treatment, that bronchodilators or vasodilators. And relieve anxiety. And a psychiatric cause of dyspnea is only made after exclusion of other treatable causes. So already said there is a psychogenic cause for the dyspnea. So while treating the conditions, we can relieve the such factors. Dual coexisting pathologies should be considered, that is chest infection, hypovolemia, while giving the treatment. Continuing with management, here we see what are the non-pharmacological interventions we can adopt for treating the patient with the dyspnea. So first of all, deep breathing and coughing exercise and chest physiotherapy. Deep breathing and coughing exercise will promote the cough out the secretions, or the take out the secretions. Then similarly, postural drainage, turning or changing the position of body, that is also help to drain out the cough and secretions in the chest. That is one of the most important thing, that is postural drainage. So here the basic principle workout is the gravity. So when they change the position to that, towards that position, the secretions will be drain out. Then biofeedback, then psychotherapy, then relaxation trainings, and acupuncture or acupressure or massage and therapeutic touch. The next condition we move on to the cough. Cough, that is also quite common medical term we come across. There is a sudden, she said a sudden, often involuntary, forceful release of air from the lungs. So how could we describe? It is described as sudden, often it is an involuntary, forceful release of air from the lungs. So etiological factors: upper respiratory infection, chronic obstructive pulmonary disease, bronchiectasis, interstitial lung disease, sinusitis, airway hyperresponsiveness, gastroesophageal reflux disease. In these situations, there is an excessive mucus secretion in the lungs. So when there is an excess mucus secretion in the lungs, automatically there is a cough reflex will work out, and it will try to drain out, otherwise try to cough out the secretions whatever lodged in the airway tract. Then similarly, cigarette smoking, common cold or influenza, congestive heart failure, and environmental pollutions, and asthma. These are the common etiological factors. There is a triggering factors that initiate or stimulate cough. So why? Because there is an abnormal congestion, there is abnormal collection of secretions in the airway, or otherwise any of the trapping of foreign bodies in the airway. So cough is a normal reflex. It will try to take out the or drain out the whatever particles stick over the airway tract. And this is the physiology of cough. So normally to start with is the stimuli. Stimuli in the sense any foreign bodies or any production, there is a secretions over there that will stimulate the larynx, trachea and bronchi. Any of these areas, whether it is a lodging of any stimuli like foreign bodies or cough or secretions or uh, any kind of particles, then immediately there is a stimulation of afferent lymph vagal nerves. Okay, so vagal nerve stimulation, so it will send the message to the cough center in the medulla oblongata. So when the cough center receives a message, immediately it will activate the efferent lymph. There is a motor nerve activations. So that will give the response, otherwise give the instructions to the laryngeal and respiratory muscles. So there develops it will cough. That is the normal physiology how cough develops. So it is a normal aspect. There is a normal stimulation, otherwise normal response to the stimuli is supposed to be helpful for the for example, if you see choking of food or any unnecessary unintentionally entry of any foreign bodies, immediately we cough. That is, our body normally responds to this kind of stimuli. Then types of cough. Based on the characteristics classified, the many types are there. Acute cough in the sense cough that lasts less than 3 weeks. Then subacute cough in the sense cough that lasts 3 to 8 weeks, and chronic cough, that is cough lasts more than 8 weeks. Then refractory cough. Refractory cough in the sense cough that does not respond to usual medical treatment such as anatomical diagnostic protocol. Okay. Then chronic idiopathic cough, that is cough with no underlying cause even after a thorough systematic review. Then specific cough in the sense a known underlying disease or causing the cough. Other than this, many other kinds of cough are there: dry cough, wet cough. So then what are the diagnostic measures? So as it is for every each and every terms or medical aspects, first and foremost is the history and physical examination and bronchoscopy. Already said, through the bronchoscopy we directly visualize the bronchi or the upper respiratory tract, and we can identify what is the triggering factor, otherwise which foreign body is entered in the airway system. Then lung scan, pulmonary function test and sputum analysis. And finally, we can do the chest X-ray to identify, rule out the more systematic way. Then management for cough, antitussives. Antitussives are the cough suppressants. Expectorants in the sense the drugs which helps to melt out, otherwise drain out the secretions. Then bronchodilators. So already said asthma is a cause for the cough. So bronchodilators which will helps for the dilate the bronchioles. So certain kind of obstructive kind of lung diseases will be resolved by the bronchodilators. Nebulized local anesthetic and topical treatments. And next term we most often come along with the respiratory is the respiratory obstruction. So here we see what is respiratory obstruction and further to what is the management and all. Respiratory obstruction, there is a partial or complete blockage of the breathing tube. There is a respiratory airway is known as the airway obstruction. Then an acute upper airway obstruction is a blockage of the upper airway which can be in the trachea, larynx or throat. So etiological factors. So if the blockage in the lumen means the etiology may be foreign body, blood clot, vomitus or any sputum plug. If it is in the respiratory wall, otherwise airway tract wall means that is epiglottitis, laryngeal edema, anaphylaxis and neoplasm. or outside the wall, in the sense the reasons will be the trauma, especially facial or neck trauma, thyroid mass or hematoma. This is the etiology. Etiology is categorized under three aspects, that is the blockage in the lumen or blockage in the wall, blockage in the outside of the wall. Okay. In the lumen causes like a foreign body or blood clot or vomitus or sputum that is entered into the airway tract itself. There is a blockage inside the tract. So in the wall, in the sense epiglottitis, laryngeal edema or anaphylaxis neoplasm, that will constrict the respiratory tract. Then outside the wall, that is no problem is not in the airway, but problem is outside the airway tract. That is trauma because of any injury. There is a blockage in the tract, otherwise thyroid mass that will compress the airway, and hematoma also that will obstruct the airway. Then clinical manifestations. So manifestations like in spontaneously breathing patients means the manifestations are stridor, dyspnea, fatigue and cyanosis. So in case the patient is ventilated, in the sense there is a raised airway pressure, decreased tidal volume, hypoxemia and hypercapnia. These are the basic features. Other manifestations are agitation, cyanosis, agitation because of decreased the oxygenation in the neurons or the central nervous system, that will elicit through the agitation, and cyanosis because of decreased oxygenation in the peripherals, choking and confusion, difficulty breathing, gasping for air or air hunger, we usually say, wheezing and panic, and unusual breathing noise indicating breathing difficulty, and changes in consciousness. These are the major clinical manifestations of airway obstruction. And the diagnostic measures. The diagnostic measures include chest and lateral neck X-ray. Other than that, the history and physical examination is basic for everything. Chest and lateral neck X-ray, we can identify the exact reason. What is the reason for the airway obstruction? Then fibrotic laryngoscopy or bronchoscopy. There is a directly we are visualizing the airway tract, and CT scan. The management options are: first, obstruction caused by an inflammatory or allergic reaction may be treated with bronchodilators, corticosteroids, and intubation and administration of oxygen. If it is because of any inflammatory or allergic reaction is the cause for obstruction, means we go with the treatment of bronchodilator, corticosteroids, and intubation and administration of oxygen. If the person has a complete obstruction, then we supposed to do this. If the person has a complete obstruction, means we supposed to do Helmich maneuver is the option for the management. So this is Helmich maneuver are a series of under the diaphragm abdominal thrust, as it is now in the videos and all you can see when a patient get with the choking or accidentally when they develop choking, as a first aid we usually do Helmich maneuver. Then objects stuck in the airway may be removed with the laryngoscope. Already said bronchoscopy or laryngoscopy. That is not only the diagnostic procedure but also a therapeutic procedure. Here we can through this directly visualize and we can remove the secretion or any stuck particles in the airway. Then finally, emergency tracheostomy. If the obstruction cannot remove or the patient is struggling to take breath, means we can, as an emergency, we can do tracheostomy. These are about the dyspnea, cough and airway obstruction. I hope you understand about this. This is the most common terminologies we come across while taking care of patients. Okay. Thank you.